Hi guys, this is going to be a relatively short chapter, and this is going to be on end-of-life care. And when we talk about end-of-life care, we usually think of children that have had terminal illnesses like cancer, for example, which is kind of why I included it in this content that I did. But keep in mind, we're also talking about other chronic conditions. So it can be heart failure, it can be liver failure, it can be cystic fibrosis. Okay, so it can be any chronic condition, not just cancer that we're talking about here. So when we're looking at chronic illness, we're looking at a condition or illness that is long term and either is without a cure or has residual effect that limits the activities of daily living. So like I said, you have some chronic illnesses that, we don't always think of as being, end of life type things. But keep in mind, any chronic illness, even if it's not physically apparent, is going to have a tremendous impact on the child and the family. And so I think about, especially where we live in Southern Illinois, that we don't have access to a lot of pediatric services here. So if you have a child with a chronic condition, the majority of the time your patient and your family has to drive at least 2 hours usually to receive specialized treatment. And that can have a tremendous impact on the family dynamics that go on. So a chronic condition that is terminal but lasts only a short time may also have serious long-term effects on their surviving family. So we have to look at, how long has the family been dealing with this? How long has our pediatric patient been dealing with this? Because the long-term effects on the surviving family can be very, very long-term, and we have to kind of be aware of that as the nurse when we're taking care of our pediatric patients. So the effects of the chronic illness on the family and the family unit. Okay, so there is the situational crisis. So this is when you have an unexpected crisis for which the family's usual problem-solving abilities are not adequate. And the big one I think of is when the family is handed that initial diagnosis. Okay, that brand new diagnosis of leukemia or that brand new diagnosis of sickle cell anemia. And so what happens is the family who normally has their coping abilities are kind of sent into overdrive at this point because, normally their normal problem solving abilities are not going to be effective in this situational type crisis that we're experiencing. So with enhancing resilience, this is where you establish and access both internal and external sources of physical, social, and financial support. Okay, so this is kind of where we come in as the nurses a lot of times, is that our job as nurses, not only to help with the physical aspect, we have to look at the social strain that this is going to have on them, the driving back and forth to wherever their new specialist is, the finances that are going to be taking a toll as well. So think about, if we're dealing with a child that has to require a hospital bed at their home or a ramp built onto their home, or just the financial strain of staying in a hotel while your child is undergoing treatment at the hospital. This really does play an impact that will really put a strain on the family. Okay, and so I've seen this where it goes either way. I've seen family cohesiveness get better. It makes them stronger as a unit. I've also seen chronic illness that has tore families apart. Okay, keep in mind, that we're assessing the family as a unit, but we also have to assess the effect on the children. So depending on the age of the child, it can actually interfere with their development. And I think about that toddler specifically, where they're really into that development of autonomy. So if there is a toddler that's diagnosed with a critical illness, this can have long-lasting psychosocial effects on that toddler, and where they really struggle to gain the autonomy for the remainder of their life. So looking at the illness experience, okay, so I just kind of wanted you guys to look at the fears of what you see for pretty specific age groups. So for the infant, their big thing is separation, strangers. So that's a big thing. Anytime you have a child, so whether we're talking an infant or toddler where they both have separation issues, that's a big thing with the parents. And what I mean by that is, we really want to encourage the parents to stay with the child as much as possible when they're in the hospital setting. Now, get it. We understand that, parents have to have a break and they have to go eat and they have to go do things. It's very important that we talk to the parents about establishing times and telling them, I will return in 1 hour, or, tell them that it is imperative, like, I am going to return. Okay, because it really does have a huge impact on them in terms of separation. For the infant, that introduction of strangers can be very fearful, and then toddler, that loss of control. So some ways that you can, help with that toddler with that loss of control. I always encourage parents to bring familiar items from home for the toddler. So maybe it's, eating utensils that they have to have, like their special forks, their special plates, their special cups. That gives them some sense of control in that hospital setting. The preschooler, their big fear is body injury, mutilation, the dark, being left alone. So little things like bringing in dolls and showing them procedures on the doll, or making sure that we have lights on at all times, like even if it's just low lighting, can help with a lot of their fears in the illness experience. School age, same thing. They have a fear of mutilation, so it's best to kind of assess what do they know about their illness, and make sure that we use basic terms and that we are forthcoming with them and that we tell them, things in basic terms, and we need to tell them about the side effects as well. Okay, because a school age child can start comprehending a lot of that stuff. Okay, and then adolescent, I don't think you guys can see the bottom because it looks like it's cut out of my screen. This is that loss of control, altered body image, separation from their peer group. Okay, so for the adolescent, we want to encourage them to socialize as much as they can. So we give them their devices, we give them their phones, we allow them to remain with their peer groups, especially during this time of illness. So our goals for the child, we want to achieve and maintain normalization. Okay, so again, this is where we bring in stuff from home. If they have a stuffed animal that they always sleep with, like, we let them bring that in. Our goal, of course, is going to be to obtain that highest level of health and function as possible. Now, our goals for the family, of course, we would love for them to remain intact. So, like I said, I've seen, chronic illness strengthen families, and I've seen it rip them apart. But whatever happens, we still want the family unit to remain intact. For the family, we also want to achieve and maintain normalization. And of course, we want to maximize function throughout the illness. Okay, so that may include getting the family some caregiver role strain interventions. Okay, so we need to make sure that not only do we have goals for the child, but we also have goals for the family unit as well. So nursing care for our children, of course, we want to attend to the needs of the family system, okay? And we need to continually revise our goals to meet the child's changing developmental needs, okay? So goals that we have, during one hospitalization may not be the same goals if the child comes back in 3 months. We always want to make sure that we listen carefully to the child's perception of the condition. And like I said before, I cannot stress enough, use basic terms to explain the disease progression and the therapy, and make sure to include side effects. These children, especially when you're getting into school age, are way more perceptive than we give them credit for. Okay, so again, we ask them questions like, what do you understand about your illness? And they will ask questions a lot of times, and they want to know, am I going to die? Okay, that is part of being honest with them about their disease progression. That is being honest with them about their therapy and the side effects. Okay, so please make sure that we do not lie to the kids. We want to make sure that we have that open communication with them, and that we have that trusting relationship with them as well. So when we get to the concept of death, children's concept of death, of course, is based on their age. Usually, 0 to 2 years, they perceive death as loss of the caretaker. They don't really look at it. Their cognitive level at that age is so minimal that they don't perceive it as happening to them. They look at it as loss of the caretaker. When you start getting that 2 to 7 years old, that's when they start understanding death a little bit, but they look at it as reversible and a temporary separation. And I use my daughter as a perfect example. My daughter, in that age range of 2 to 7, she never met my mom. My mom passed away before she was born. and she understands that she is dead, but in her mind, it's still like reversible. Okay. They always look at it as reversible, and this is temporary. So even if they have like a loss of a pet or loss of a family member, like their concept is like, oh, this can always be reversed. When you get to ages 7 through 12, they understand that death is sad, it's irreversible, but it's not necessarily inevitable. Okay. So they don't perceive themselves as dying. Okay. They may have lost grandparents, they may have lost pets, and they know it's a sad time, but they don't always look at it as this could happen to me. And then when you get to that 12 years on up, this is when they start understanding and they have that abstract thinking, like death is inevitable and irreversible, but it's often like a distant event. So, 12 years old, they're like, yes, I understand I'm going to die someday, but it's not going to be for a very, very long time. So that's just kind of how the concept of death is for pediatrics. So nursing care for the dying child. Okay, so here's what our role as the nurse. We want to be available to assist the child and the family. Okay, the dying child a lot of times is kind of aware that it's happening. The family, although sometimes in disbelief, they a lot of times will know like when the end is getting near. We want to avoid any imposing personal beliefs, and I see this a lot when you have families that talk about complementary therapies. That's the big one I see, where you have a lot of families who are into like aromatherapy, um, essential oils, for example, things like that. You are not to impose your beliefs on the family. I've seen some family, and I'll talk about this when I get to pain control, who will prefer to do alternative therapies as opposed to medicinal therapies. Okay, it is not our decision to impose our beliefs on this family. Okay, we have a therapeutic team for a reason, and as a group, we talk to the family and we talk about what all of our options are. And again, we are there to assist the child and the family in this transition. We also want to remember to give attention to the siblings of the dying child. A lot of times you will have the siblings that are just kind of left over to the side while the family is grieving the loss of that child. We need to keep in mind that this sibling is losing, their brother or sister as well, and they need to have attention. Their feelings need to be validated as well. We need to recognize the need to talk about the illness and death. So you want to encourage the family to continue talking to the dying child, even if the child may not respond. Okay, hearing is one of the last senses to go for a lot of times. So we encourage the family to be there at the bedside, talk to them. Sometimes they'll rub their backs or hold their hands. Like, we want to encourage that. Now, again, we don't want to force them if they're not comfortable doing that, but it is something that we do want to encourage them if that's what they wish to do. We provide pain control, oral care, privacy, and information about the signs of imminent death. So there's something that you'll hear a lot of times, what we in healthcare will call the death rattle. It's a very specific type of respiratory pattern that you hear where they have periods of apnea. And in healthcare, we kind of know those signs, or we'll start seeing the heart rate start slowing down. We'll start seeing respiration start slowing down. Level of consciousness will be a lot more here and there. So we want to make sure that the family knows when time is getting close. We still provide pain control if that's what, up until the very end. We still do oral care. We provide signage outside the doors a lot of times so that the visitors know that we have someone that is dying in that room, so that we can be quieter outside of the room. We want to explain what to expect in that immediate post-mortem period. So a lot of times as healthcare workers, we like to clean up the child's body, or any, even adult patients, we do this. We clean up their body before we allow the family to come in. But sometimes the family may want to help participate in the post-mortem care of the patient. So if they want to help give the bath, if they want to help prepare the body, that is okay. Okay, so we should be offering that to them if that's something that they want to do. And after death, we allow the family members as much time as they desire with the child. Like, we do not put a limitation on the time. So if they want to sit in there for 6-8 hours, we do that. Okay, that's just part of the thing that we do as healthcare providers, is we allow them as much time as they need with their loved one. Now, for grief after death, you want to make sure you support the family during the dying process. And, I realize I've been talking a lot about, when we expected death. keep in mind that sometimes this is really sudden. And a lot of times, there's a lot of family who hasn't had time to process what was happening. So if we're dealing with an unexpected death, so maybe it was something that we just didn't see coming, one of the things that we allow families to do, and depending on where your hospital is we a lot of times will allow the family in during like a code, for example. Okay, and I'll talk about this when we get to our pediatric clinic days, and we'll talk about your feelings behind this, because this is a huge thing that I personally advocate for, because a lot of times it gives the family closure. So if they're in there and they're help like watching the code process happening, they realize that we were doing everything that we possibly could during the code situation, and they aren't sitting in a room by themselves wondering what is happening to their loved one. But again, and I will talk about this again with more with clinic, we shouldn't force the families in there if they don't want to be in there, but it is something that we should offer them if your hospital allows it. After, while we have, things happening going on, keep in mind the family does not want to see their child suffer or in pain. So most of your family are very, very good about, when we come in with our hourly morphines and our atropine to dry up the secretions. They just want to make sure that we're doing everything that we can to make the transition to death as painless as possible. Other things to remember is that grief is similar for all people, but it can be processed differently by everyone. It is also important to remember that loved ones have to understand that the person who has died is gone. So a lot of times it's important to use concrete terminology. And again, this is something else I'll talk about in Peds Clinic. You can't say that they've passed on or we've lost them. Those are really bad words to say. So we want to make sure we use concrete terminology like they have died, okay? We also want to acknowledge and allow the family to experience whatever their emotions are. Everybody deals with grief in different ways, okay? Some people are very emotional. Some people are very stoic, okay? And it's not in our best interest to judge how they react to death. Like I said, everyone deals with it very, very differently. And of course, like our goal after death is that the family members can reinvest in life and go forward with their lives. And as nurses, we want to try to provide them the best outlet for that. So we will give them follow-up resources. We can have social workers check on them. But again, our goal is to help them move on, not forget, but to move on so they can have full functioning lives. Okay, thanks.